Continuous Labor Support and Cesarean Section Rates by Janet Carrillo, Amy Deneau, Kelly Lewis, Kelsey Meyer, and Jessica Sisson. The U.S. cesarean section rate is at an all-time high of 32.2% in 2014 and climbing steadily since 1997. The existing research reflects a positive correlation between continuous labor support and reduced cesarean section rates in low-risk deliveries. Our objective is to evaluate the effectiveness of intrapartum nurses as providers of continuous labor support. The theoretical framework used for this project is the Iowa model of evidence-based practice to promote quality care. The Iowa model fits this study as it describes the impact of new knowledge on the implementation of clinical practice improvement. It also emphasizes consideration of the whole medical system, comprised of provider, patient, nurse, and hospital. The steps for the Iowa model are as follows. Identify a priority problem-focused trigger that will initiate the change. Review and critique relevant literature. Identify research evidence supporting change in clinical practice. Implement the change in practice, and monitor the outcomes. Here's an algorithm for the Iowa model. Using the Iowa-based model of evidence-based practice change, we identified priority triggers to action that should be a priority for our organization. The priority problem-focused trigger for this study is the internal and external benchmarks of cesarean section rates. In 2014, the nationwide cesarean section rate was 32.2% and 33.38% for our hospital specifically. Knowledge-focused triggers include recent recommendations by national and international organizations, such as the World Health Organization, the Joint Commission, the Society for Maternal and Fetal Medicine, the American College of Obstetrics and Gynecology, the American College of Nurse Midwives, and the Association of Women's Health and Obstetric and Neonatal Nursing. These organizations publish various statements aiming to reduce the number of primary cesarean section rates down to at least 23.9%. They urge hospitals to take measures to decrease primary cesarean sections, including implementation of continuous supportive care. A 2014 practice consensus published by ACOG and SMFM addresses rising cesarean rates in the United States. In their consensus, they state that 1 in 3 women have cesarean section rates without evidence of concomitant decreases in neonatal or maternal morbidity or mortality. The consensus urges healthcare providers to implement practice measures aimed at safe prevention of primary cesarean sections. Furthermore, the Joint Commission has issued a National Quality Core Measure, Perinatal Core Measure PCO2, to address the rising cesarean section rates, stating, there are no data that higher rates improve any outcomes, yet the CS rate continues to rise. Finally, as part of the Healthy Birth Initiative established by the American College of Nurse Midwives, the organization asserts that unwarranted variation in cesarean sections for low-risk women across the United States indicates a need for change to reduce primary cesarean sections. AWAN also states that labor support is the most fundamental role of the intrapartum nurse. Finally, Cover California's new policy states that beginning in 2017, it will no longer pay for primary cesarean sections in low-risk NSBT pregnancies in hospitals with cesarean section rates higher than 23.9%. Other triggers that we identified for our project include the patient's level of satisfaction and expectations for support provided during the intrapartum period. Women reported emotional support as the most helpful behavior of intrapartum nurses during the labor and birth process. It also included variation in cesarean section rates amongst hospitals, the attitudes and influence of the physician, hospital, L&D unit, and nurse, the nurse's training on providing bedside support, the patient's knowledge, and finally the health of both mom and baby. Cesarean sections can be life-saving in many situations in which mother and baby are at risk of morbidity or mortality. However, the cesarean section rates currently experienced by U.S. hospitals do not reflect the acuity of the patient population. Cesareans that are not medically indicated are often termed unnecessary cesareans. C-sections are costly. The costs continue to rise each year, averaging nationwide between approximately $17,000 and $24,000 in 2011. Cesareans are also more expensive than vaginal deliveries by approximately $5,000. Cesareans can result in a myriad of maternal and fetal complications. Maternal complications include infection, hemorrhage, bladder injury, and uterine rupture. They require a much longer hospital stay, approximately 2 to 3 nights, and can require up to 6 weeks of recovery time for the mother. Cesareans can result in negative implications for baby as well. Respiratory problems, incomplete emptying from lungs and stomach as a result of not being compressed through the birth canal during vaginal delivery, and missing out on exposure to the beneficial bacteria found in the mother's vagina are some of these complications. Additionally, every culture through time has incorporated the support of women by another, providing continuous labor support. The PICO question for this study is, in laboring women with low risk, nulliparous term vertex singleton pregnancies, does continuous labor support by a nurse decrease likelihood of cesarean section compared to laboring women who do not receive continuous labor support by a nurse? Our population is laboring women with low risk NSVT pregnancies. Exclusion criteria include non-NSVT pregnancies, preterm, multifetal breech, multiparous, and TOLAC, or trial of labor after cesarean, are excluded. High-risk complications such as placenta previa, uterine rupture, or placental rupture are also excluded. And finally, high-risk conditions such as gestational or chronic hypertension, preeclampsia, and diabetes are excluded. Our intervention is intrapartum nurses providing continuous labor support consisting of physical, emotional, advocacy, and education. The comparison is usual intrapartum nursing care. Our outcomes primarily are decreased cesarean section rate, and we will also evaluate secondary outcomes of patient satisfaction. The goal of our literature search, review, and critique is to identify, evaluate, and synthesize current research and evidence to address our PICO question. Does CLS decrease the likelihood of a cesarean section? The goal of the literature review is to generate knowledge of current available research needs, uncover consistencies and inconsistencies, and identify where more research could be helpful. We focus our search using the PICO question in low-risk laboring women. The research question was then applied to find what evidence was available. The Cal State San Marcos Library Proxy was used to search 4 different databases: PubMed, CINAHL, Cochrane, and Google Scholar. The researchers used 4 search terms: nurse labor support, continuous labor support, labor, and cesarean section, and these could have been combined in any way. Articles which met the following criteria were reviewed and addressed in our literature critique. They had a standard research design of one of these main 4: a randomized control study, a systematic review of controlled studies, secondary analysis, and meta-analysis. Additionally, the literature included needed to be peer-reviewed information written in English, have a target population of hospitalized pregnant women 18 years of older, and any age above that, race, ethnicity, research focused on outcomes for patients such as cesarean sections versus vaginal deliveries with support systems as the main topic. The results of a Cochrane review have been widely disseminated in practice guidelines in the U.S. The publication recommends continuous caregiver support for all women during labor, resulting in the reduction of C-section rates. In the studies analyzed by the review, continuous labor support was provided by a variety of women and men. Only a handful of studies have provided evidence where the intrapartum nurse was the provider of CLS, one of which is inconsistent with findings from the Cochrane Review and demonstrates no difference in C-section rates among women who received CLS and women who received usual care. The grading scheme used to grade the evidence was the American Association of Critical Care Nurses Levels of Evidence. According to the AACN, the purpose of determining the level of evidence and then critiquing the study is to ensure that evidence is credible and appropriate for inclusion into practice. This particular grading scheme rates the level of evidence according to the design of the research as shown above. Each piece of the research literature was given a grade based on criteria from the AACN guidelines. Any articles which were D, E, or M were also not included in our guides. Continuous support for women during childbirth was a meta-analysis of 22 trials involving 15,288 women, and our leading piece of evidence in the literature review. According to the AACN grading scheme, it is a Level A evidence. The purpose of the review was to assess the effects of continuous one-on-one intrapartum support compared to usual care, and results demonstrated that women allocated to CLS were more likely to have spontaneous vaginal birth. From the article, Doula Support While Laboring, Does It Help Achieve a More Natural Birth?, the research purpose was to address if the use of the doula lowers rates of analgesia, epidurals, and C-sections. The research design of the study was a systematic review of 8 different research articles, including meta-analyses, systematic reviews, RCTs, and retrospective studies. The results of the study were as follows: that there is evidence to support the use of a doula for continuous labor support to prevent analgesia, epidurals, and reduce C-section. Using the AACN evaluation on the previous slide, we determined that this article in particular was a Level A, meta-analysis of multiple controlled studies with results that consistently support a specific action, intervention, or treatment. Historically, across many cultures, women have been attended and supported by other women during labor and birth. However, as the birth environment transitioned from the home to the hospital in the mid-1900s, continuous labor support has become the exception rather than the routine. Evidence from the literature indicates that continuous support during labor has clinically meaningful benefits for women and infants and no known harm. Therefore, all women should have continuous one-on-one labor support through labor and birth. Continuous labor support should be provided by the intrapartum nurse as to improve birth outcomes and lower C-section rates. One-on-one nurses should remain with the patient except for 30-minute lunch breaks and up to 10 minutes during each 4-hour period for breaks. In the case of labors lasting longer than 10 hours, the nurse can either remain with the woman or call in another supportive nurse to replace her. The central component of continuous labor support is continuous bedside presence during labor and delivery, with an emphasis on social support over medical interventions. Labor support, as defined by Hodnett in 2013 Cochrane Review, is very similar to the common definitions of social support. Integration of Reva-Rubin's social support theory and Hodnett's definition of continuous labor support provides the foundation for intrapartum nursing care and continuous labor support. One-on-one continuous labor support consists of presence of a nurse during labor and birth who provided emotional support, physical support, instruction and information, and advocacy. Emotional support measures include encouragement, reassurance and praise, caring attitude, presence, therapeutic humor, refocusing, distraction, and coping techniques. Physical support includes therapeutic touch, effleurage, massage, hydrotherapy, promoting changes in position, aromatherapy, applying cold or warm compresses, and promoting ambulation. Information and instructional support by the intrapartum nurse during labor and birth allows patients to participate in decision-making process, which fosters patient empowerment and a positive birth experience. These include instruction for breathing, relaxation, pushing, and partner care, and information about patient care, routines, and procedure. Another facet of continuous labor support is advocacy, in which the nurse should convey respect, acknowledge mother's expectations for labor and birth, including informed decisions, birth plans, listening to the mother's wishes. She should ensure security and facilitate conflict resolution. Nurse leadership roles, including nurse managers and charge nurses, will direct the implementation of continuous supportive care intervention. During a 40-hour initial training period and quarterly refresher workshops, labor and delivery nurses will perform a critical review of the existing scientific literature concerning the effects of continuous supportive care in labor. With the help of a doula and midwife, departmental nurse leaders will train and educate the nursing staff in the role of providing one-on-one labor continuous support. The nursing staff must perform a return demonstration of all techniques and rationale of use in order to pass the training course. All labor and delivery nurses must pass the training course prior to providing further care on the unit. Once training is completed, the continuous supportive care intervention will be implemented on the L&D unit. Nursing leadership will continue to monitor the performance of supportive care techniques and ensure that evidence-based practice guidelines are implemented correctly. All nurses will receive a bi-monthly evaluation and critique of their delivery of continuous supportive care. Here's an overview of the 40-hour training curriculum as shown above. Curriculum may be altered depending on the knowledge and ability of the participants. The objectives of our evaluation plan to monitor the effectiveness of the implementation of a continuous labor support evidence. The objective of our evaluation plan is to evaluate the effectiveness of the implementation of a continuous labor support evidence-based practice change on reducing primary cesarean section rates. Using consistent data collection and statistical analyses, we will want to determine whether a difference in our outcomes of interest exists before and after practice change. The primary outcome of our practice change is to measure cesarean section rate. Secondary outcomes include measuring women's perceptions of continuous labor support provided by intrapartum nurses. Furthermore, to evaluate the process of implementing a practice change and identify any barriers to change, another secondary outcome will measure intrapartum nurses' knowledge and perception of CLS. To affect change, a change in attitudes or unit culture often must occur. Therefore, evaluation of nurses' perceptions of CLS before and after our practice change will address this concept. Demographic data will be collected for both nurses and women to identify whether differences exist within and between groups. To evaluate our plan, we'll use the following statistical techniques. ANOVA is used to determine whether a statistically significant difference exists between more than two groups and can also be used to determine whether differences exist between and within groups. Using this statistical technique, we hope to determine whether implementation of our practice change results in statistically significant difference in cesarean section rates, mean nurses' knowledge and perceptions, and mean mothers' perception of CLS. We'll also collect demographic data with each to allow us to determine whether any statistically significant differences in demographics exist and allow us to identify possible confounding factors. The F-test statistic will be used to identify differences between and within groups for outcomes of interest. The F-test is similar to the T-test but used for ANOVA, and to determine whether a statistical difference in group means exists between more than two groups. This test can be used since the dependent variables are measures. Here's an overview of our evaluation design. The design will be a quasi-experimental repeated measures design. We selected this to evaluate the effectiveness of our EBP intervention as it's an effective design to measure change. The schematic and notation is shown here. To measure our primary outcome of cesarean section rates, historical data for cesarean for cesareans will be collected for 12 months prior to implementation of intervention, or EBP practice change. Baseline data for secondary outcomes of mothers' perceptions of continuous labor support received and nurses' perceptions of continuous labor support provided will be collected once in the month prior to implementation of our practice change. Following implementation of our practice change, data will be collected for C-section rates monthly for 12 months. Data will be collected for secondary outcomes monthly for 12 months. The Bryanton Adaptation of Nursing Support in Labor questionnaire uses a Likert scale to assess women's perception of various labor support behaviors provided by intrapartum nurses in the birthing process. Labor support behaviors are divided into 3 categories: emotional, informational, and tangible support. Women provide responses using the Likert scale from 1 to 5, where 1 indicates women perceived a particular labor support as not helpful, and 5 indicates very helpful. Furthermore, women have the option to indicate whether the labor support behavior was not performed. Here's an example of the BAN-SILQ instrument to give an idea of the types of labor support behaviors that women evaluate in the questionnaire. Reliability reported in the literature is high. There's an internal consistency reported by Cronbach's alpha of 0.99, and the subscales for emotional, informational, and tangible support are reported as 0.91, 0.84, and 0.71 for emotional, informational, and tangible support, respectively. Validity is measured as content validity and was established by a panel of 5 experts, including 2 nurse midwives, 1 maternal child nurse educator, and 2 labor and delivery nurses. To measure intrapartum nurses' perception and knowledge of labor support provided during the labor support questionnaire will be utilized. Understanding nurses' perceptions of labor will help to identify changes in nurses' attitudes, knowledge, and identify barriers that will be helpful in the evaluation of the effectiveness of our project. It's divided into 3 parts: attitudes, intended behaviors, and perceived barriers to providing labor support, with 6 defined dimensions, including tangible, advocacy, emotional support, reassurance, creating control, comfort, and safety, caring behaviors, and informational support. This is also a Likert scale, where nurses can rate 0 as not important or 5 as important and always used. Here's an example of the LSQ in part 2 and part 3. Reliability reported in the literature for the LSQ is also high. Internal consistency reported as Cronbach's alpha is 0.92 and 0.86 for part 1 and 2 respectively. It is not reported for part 3, and the subscales internal consistency varies from 0.67 to 0.9. Validity reported in the literature is reported as content validity index as 0.94 and is high. The California Maternal Quality Care Collaborative's Maternal Data Center allows hospitals to track monthly, quarterly, and annual trends in cesarean section rates. We propose utilization of this tool provided by the CMQCC to measure cesarean section rates in our identified population. According to the website, recent trends, including rising rates of maternal morbidity and mortality and increased utilization, not reading that. Our setting is comprised of a specialized L&D hospital in urban, not-for-profit San Diego County. The staffing includes RNs, registered nurse, MDs, DOs. There's a doula program at an additional cost and no certified nurse midwives. In 2014, there were 9,663 births annually, and the percentage of low-risk births delivered by cesarean section in 2014 was 33.8%. Demographics for our patient population, the primary age range is from 30 to 39. It's primarily white, non-Hispanic, and English-speaking, and insurance is primarily accepted Medi-Cal and private insurance. Our sample size was calculated to provide an alpha of 0.05 for the level of significance and a power of 0.80. We have two samples. The first sample is the cesarean section rate. We'll recruit 384 low-risk deliveries over a 2-year period. And the second sample will evaluate our secondary outcome. And this will be a nurse-patient dyad. And we will need a sample size of 299, which is 13 monthly measurements. So nurses may participate in more than one survey. Informed consent will be obtained from each participant, the nurse and patient, prior to completion of study questionnaires. Data will be collected from historical hospital records a year before to establish C-section rates without intervention. Once the intervention takes place, data will be collected in the form of decoded hospital records for C-section rate and from questionnaires from a patient and nurse dyad at monthly intervals for a year. Baseline data will be collected from a selection of nurse-patient dyads for 1 month prior to implementation of our intervention. At the same time, demographic data will also be collected on each participant. All records will be kept confidential and will be stored in a locked file cabinet in a locked office. All data will be kept in a password-protected computer with de-identified spreadsheet. Only the researchers will have access to the computer. Coding and scoring will be performed according to the original author's recommendation. The first questionnaire, LSQ, is a 3-part questionnaire that has a potential score of 0 to 135. The first part is based on a 6-point Likert scale with 0 indicating not used or not important and 5 blah blah blah. The third part is yes or no. The second survey is the Bryanton Adaptation of Nursing Support and Labor Questionnaire. It measures frequency of behavior and has a potential scores of 0 to 125. It has 6-point Likert scale with 1 on the Likert scale indicating that behavior was not helpful at all, whereas a 5-point would indicate that the behavior was very helpful. A 0 on the Likert scale indicates that the behavior was not applicable to this particular instance. Bias in our study can result from the sampling, as the population in the hospital may not accurately represent demographics of the general population and will also be conveniently obtained. The sample will not be random. Women laboring outside the hospital setting and those who do not meet inclusion criteria are excluded from the study. There's also a risk for self-report bias since we'll be relying on an open honesty from participants in their experience. Also, inconsistencies in the applied intervention may pose a threat to internal validity. Therefore, nursing leadership must monitor the performance of applied intervention to ensure those implemented appropriately. For example, bi-monthly evaluations will be provided and maintain validity. Furthermore, the study will not be blind. All participants will receive continuous labor support. To ensure ethical practice, all patients and nurses will sign an informed consent form with risks and benefits clearly outlined. All of the data will be kept confidential, and this is the primary ethical consideration for our study. All documents and papers will be kept in a locked file cabinet. This concludes our presentation.